Degenerative disorders. As you know, the patient can have low back pain for quite a long time. And low back pain is quite a debilitating problem, especially if the patient is an old age patient, because the movement, the activities of daily life, all that would be very much hampered. So one of the causes of low back pain and degenerative disorders of spine is spondylolisthesis. What is spondylolisthesis? As you know, spondylo means of the vertebra and listhesis means slip. In this, one of the vertebra actually slips forward over another. Now there could be multiple causes of this slip. This could be a problem with there could be a congenital anomaly in which there is actually the formation of the vertebrals are not that much, as a result they slip over or they are unstable. There is a defect of pars intercalaris, as a result this slips over occurs, or when the patient has become old age. For example, patient may be around more than 60 or 65 years of age. Due to degeneration of the spine, due to the degeneration of the stabilizing factors of the spine, for example, all the ligaments which are connecting one vertebra to another, once they degenerate or there is actually their stability decreases, as a result one vertebra slips over another. Broadly, they could be defined as isthmic and degenerative, but there are other classifications as well. And one of the way of classifying this is on different types of degenerative slips. For example, we can classify them as dysplastic. As I told you, dysplastic means the problem lies with the vertebra. The vertebra are inherently unstable and they are dysplastic. They are not well formed. As a result, there is always a chance that they usually slip over another. Usually with isthmic and dysplastic type, they present early in life. What we see, if the child with an isthmic or a dysplastic type would come, that would be probably around of teenage years. Usually you see 14 years, 15-year-old female, especially their athletes and gymnasts. Usually involving the gymnastics is a kind of an activity which actually puts a lot of stress over the spine, especially over the lower back. Therefore, increased activities, especially like gymnastics, puts a lot of stress on spine. And although the spine is inherently unstable, therefore these patients usually complain of having a chronic backache or especially which increase with the activity and especially with the gymnastic activity. Therefore, other type could be the isthmic type. Isthmic is classically where you have a deficiency of pars intercalaris. This is because the pars intercalaris is deficient. The vertebra has a tendency to slip forward, and as a result, when a lot of stress is being placed, especially during the gymnastic activity, this slips forward, leading to this sort of a problem. Dysplastics can present a little early as well, but usually the age is around teen years, because that is where the maximum activity, especially the athletic activity, is actually occurring in the life. Other is degenerative. Now, the degenerative usually do not present early, rather they are present after the 60 years of age. Over the repeated years of cyclical loading, eventually the degeneration has occurred in the disc as well. There is a degeneration of the spinous processes as well as the facets, ligaments, as well as the vertebral bodies. As a result, this vertebra which were inherently unstable now have become more unstable over the period of years due to certain degenerative process. For example, the disc degenerate, it loses water, it loses proteoglycans, it loses collagen as well. There's only increase in the keratin sulfate, but that is the problem with the loss of all this chondroitin sulfate, collagen, and proteoglycans. This disc becomes stiffer, and as a result, the activity is decreased. And once the vertebra move during the flexion extension, they are inherently unstable and leads to slip. Therefore, you have to understand with the aging process is associated with the degenerative spondylolisthesis as well. Then could be traumatic as well. For example, there was problem, the acute history of trauma. Patient got stabilized later on, but that actually, for example, there was a flexion distraction injury. Now that resulted in a lot of loss of the ligaments and problems. As a result, this spine is unstable, and the patient will present with the traumatic spondylolisthesis of the one vertebra over the other, because the constraints or restraints of the spinal column which were present, for example, all the posterior ligamentous complex is actually now gone, and as a result the middle segment is unstable and it moves forward. Then it could be pathological as well, maybe associated with some form of a tumor or a metastatic bone disease, which may or may not present with spondylolisthesis as well. There may be a lytic lesion which may present eventually predispose the patient to increased slip or spondylolisthesis. Then iatrogenic, usually it's a very rare cause, but it can occur especially during the spine surgery, in which the posterior ligamentous complex may be damaged during the surgery. As a result, post-operatively patient may present with some form of a slip leading to spondylolisthesis. Then comes the pathology. What you need to understand is that what happens here with the, depending upon what is the cause of the slip, that is actually underlying problem. For example, if you're talking about dysplastic or isthmic type, dysplastic type, in which this actually the vertebrae are not well formed. As well, they're not well formed means their constraints are also not well formed as well, and when the stress will come, they will lead to increased slip. This is a dysplastic type of a type 1 vertebra. You can appreciate it over here. You can appreciate the disc is actually protruding along with it, because the anterior longitudinal ligament, which is the strongest one in the vertebra, is gonna be where the main weight bearing will occur. But if there is something wrong with the other areas, that means there will be increased stress on this ligament, and as a result eventually it will fail and lead to forward slip. This is a type 2 isthmic type, in which there is actually a defect of the pars defect. Although at this time there is very little slip, if you can appreciate over here, compare L5 is slipping forward over the sacrum or S1, but there is a very small amount of slip, but this can increase as the time progresses, because the problem is with the defective spondylolisthesis. There is a special sign called a sqadia sign, which has to be seen on the axial lateral view, especially of the lumbosacral spine, because sqadia means there is actually defective pars integralaris. Although at the moment the patient may not be having a slip, but as the patient's activity is going to increase in the teenage year, if he or she happens to go into gymnastics, this probably would result in increased slippage later on. This is the type 3 type. This is due to the segmental instability, which may be caused by, as a result, the aging process which has caused the degeneration of the spine. This degenerative spondylolisthesis eventually predecessors spine to more instability, leading to degenerative type of spondylolisthesis. What are the clinical features? What do the patient present when they come up with the spondylolisthesis? The first and foremost is always the low back pain. Low back pain is a very common symptom, and it's very it could be multiple other causes which may be leading to low back pain. So with the low back pain, you have to think of other causes as well. Then there may be associated buttock pain. As a result, it can sometimes mimic the features of cauda equina as well, for example, but the classical symptoms of urinary and bowel incontinence are usually absent. So there's some form of side anesthesia or buttock pain as well, a radiating pain towards the buttocks and the hamstrings or the thigh, posterior aspect of thigh. But usually if they are present, that means they may mimic the cauda equina, but sometimes it's actually underlying cause of spondylolisthesis. Then may be associated with idiopathic scoliosis, which has been left untreated because the spine is segmentally unstable. There is extra load on one side rather compared to the other. As a result, the one of which there is overloading, the spine actually slips forward. This may be associated with idiopathic scoliosis, degenerative spondylolisthesis, or even the cauda equina syndrome as well. Now coming to maybe patient presents with some form of a gluteal atrophy or a flat buttock syndrome. There may be, in the dysplastic types, there may be actually a problem with the orientation of the sacrum. They may be too vertically oriented, or the facet joints may be abnormal, or they may be abnormally placed, or they may be dysplastic, leading to increased slippage. Then lumbosacral spine pain and increased actually extension. The most common symptom is actually that the pain usually the patient has hyperlordosis, or actually the lumbosacral spine is in more lordotic posture as compared to normal, because what happens is This vertebra slips forward, the other vertebra fall backward, leading to hyperlordosis of the lumbosacral spine. There may be associated with hamstring tightness. Why? One cause could be due to the hyperlordotic and muscular spasm. Other causes could be associated with the radiculopathy, and sometimes it does mimic actually the caudal equina syndrome as well. Then nerve root tension because of hyperlordosis or radiculopathy may be present as well, and this may present with dysthesias, paresthesias, and sometimes even the muscle weakness as well. All these symptoms actually mimic spondylolisthesis, spinal stenosis, caudal equina syndrome. All they may actually have an overlapping symptoms. So you have to be absolutely sure. You have to take detailed history, then go for examination. Go for all other signs of the upper cervical myelopathy as well, because sometimes the patient with problem may be higher up, and patient may be having an upper motor neuron symptoms, and the patient may have only associated back pain, which may not be the actual cause of the problem. The problem may be have up in the cervical spine. So you have, after examination, you have to look for it that there is no associated spinal stenosis, or there is no caudal equina syndrome, or other causes which may mimic spondylolisthesis as well. And then once you're sure, then we go for some form of investigation. And as it may present as a spinal stenosis as well, or it may even eventually complicate into spinal stenosis. The spinal stenosis may initially present with spondylolisthesis, and spondylolisthesis may eventually complicate into spinal stenosis. That is something you need to remember, because once the slip occurs beyond certain level, then this may lead to this form of a problem, and eventually spinal stenosis may occur. Or radicular pain, which is due to the nerve root tension or nerve root entrapment over when it is exiting the foramina. Now imaging. First and foremost are always the X-rays. X-rays, you get an AP and lateral view of the X-ray lumbosacral spine. On AP view, you judge the overall alignment. If there is no coronal bending, for example, in form of scoliosis, and then you can also judge on the lateral view whether there is no hyperlordosis or kyphosis of the spine as well. Once you look at this X-ray, if you can appreciate it over here, this is the line of the sacrum, and this is where the L5 is. If you can appreciate, it's actually slipping forward. I'm not sure whether you're able to do it or not, but if you can appreciate it over here, this is how the isthmic, there's actually a defect of the pars denticularis, and it's actually causing there's a fibrous union between them. As a result, this is not a true syndesmotic joint, this is a fibrous joint, and as a result, this is actually slipping forward. Now there is another classification called as Marding classification. One way of classifying is as per cause of the problem. For example, it could be dysplastic, isthmic, degenerative, traumatic, pathologic, or even iatrogenic. But Marding classification basically describes it on the basis of how much slip has occurred. If it is from 0 to 25% or 1/4, this is grade 1, 25 to 50% is grade 2, 50 to 75% is grade 3, 75 to 100% is grade 4. Now this, once it goes beyond 100, this is called as grade 5 slip or spondyloptosis. Now this is one way of classifying it, the degree of slip, or how much slip has occurred, so that we may know what is the severity of the slip. Why it is important? Because if we have grade 1 slip or grade 2 slip, then we can fuse L5 or S1. If this is a grade 1 slip of L5 over S1, we need to just fuse them. But if this would have been a grade 3 or 4 slip, and this would have been present over here, then this would be too unstable for the fusion. Then we may have to fuse one level above from L4 till S1. That is why we get an X-ray, we do the grading, so we need to know the severity of the slip. If it's less severe, we can just fuse the two segments which are actually slipping over each other. But if it's more severe slip, for example, L5 is slipping over S1, but it's a severe slip, then you may have to fuse all the way from L4 to S1, not just from L5 to S1. So that is why the X-rays is important. Then plus you also get to know what is overall, so how much osteopenia is there, how much degeneration is there, what is this, whether if the young patient comes to you, is there any isthmic past defect or not. That all is also actually seen on the x-rays. That is how we go for an AP view as well. You can appreciate there is something wrong, there is some form of spinal stability on the AP view as well. Similarly, you can appreciate again, this is a different L4, L5 slip. Usually isthmic type or adolescent spondylolisthesis is usually common at L5, S1. But with the degenerative type of spondylolisthesis is more common in L4, L5. This is another form of spondylolisthesis showing at the L4, L5 level, and we can appreciate that on X-rays. What else we can go for after X-rays is usually the MRI. Until unless MRI is contraindicated, you can go for CT myelography, but usually MRI is more than enough, not only to judge the slip, but also see whether what is actually happening with the canal, is it stenosing or not. What do we see it on MRI? If you see it over, this is a bony cuts of an MRI, you can appreciate the dysplastic pars ventricularis, and this probably is a young child who has presented with low back pain due to the defect of pars ventricularis, and there is some form of instability and forward slippage of L5 over S1. Now, once we have made the diagnosis, we have taken the history, we have made the diagnosis, and we have taken the x-rays, and we know the root cause of the problem. It could be a pars defect, or it could be a simply problem of the degenerative spine that's leading to degenerative form of spondylolisthesis. It could be a pathological or traumatic cause, or it could be iatrogenic cause. Now, depending upon what is the cause, the initial treatment for most of the spondylolisthesis is always conservative. That in conservative treatment includes short-term bed rest. For example, if a child comes to you with the isthmic type of spondylolisthesis and he or she happens to be a gymnast, then probably the first and foremost thing is you have to give him or her bed rest as well as some form of activity modification. Because unless you're going to stop that gymnastic for a few weeks, this thing is not going to go away. And then activity restriction is the second option which needs to be done. Pain medication, which includes NSAIDs as well as other centrally acting medicines as well. And sometimes you may have to give, instead of giving NSAIDs, you may have to go for centrally acting opioids as well, so that the pain can also be managed, as well as the patient may have associated other issues in which the NSAIDs may be contraindicated as well. Then muscle relaxants. Why? Because the muscles are usually in spasm because of the dysplastic and segmental instability of the spine, and usually muscle relaxant actually decreases the degree of pain the patient may be having due to muscle spasm. Then steroid injection, a good short-term relief. Once the activity modification and NSAIDs haven't worked out, patient can be actually given steroid injections. Could be so that relieve the patient for a few months. But if the patient relapses, right, or patient comes back after 6 months to 9 months or 1 year time, and despite all the bed rest, activity modification and steroid injection, still nothing is working out, then probably he actually requires some of a surgery or a fixation or stabilization, so that the instability of the spine gets done and dusted, and patient spine is stable enough so that muscle do not go into spasm again and again. And yes, we do need physical therapy over that period when which the conservative treatment is actually being done. But if the conservative treatment fails, or if despite having all the measures been taken by the conservative treatment, patient's quality of life is actually not improving, then you probably will have to go for some form of surgery. Surgery depends what are the indications for surgery. Mainly the problem is with if it's a significant neurological compression. As I told you, as the slip is going to progress, this actually decrease the canal diameter, and this may be associated with neurogenic claudication and spinal stenosis. If spinal stenosis starts to occur or the neurological compromise starts to occur, then probably it's a very high time that you need to intervene and do something about it. Other indication for surgery is actually the loss of daily living activities, although this is a relative indication, because despite the patient following all the regimens of physiotherapy, steroid injection, NSAID, activity restriction and modification, but patient is actually not coming back to its normal life, what it used to be before all the problems started. Therefore, this is a kind of is time that you probably need to fix the spine so that the patient can carry out on its activities of daily living, which he or she used to do before all the problems actually started. And then the one option is more than 50% slip. That is, by definition, it's grade 3, 4, or 5 slip. That is, as I told you, why this is important, because grade 1 or 2 slip, that is from 0 to 25%, 25 to 50%, is considered as a less severe slip. But any slip in grade 3, 4, or 5, that is from 50 to 75, 75 to 100, and more than 100% slip is actually severe slip. Not only you need to fuse one level above, as well as you need to go for some form of surgical treatment, because otherwise it will remain unstable and further progress to slip, and it will eventually may lead to some form of severe spinal stenosis. Then what are the different types of surgeries? Different types of surgeries include, for example, for spondylolisthesis, you can go for different either anterior or for posterior fusion as well. You can go for posterior instrumented fusion with or without decompression. Sometimes decompression with instrumented fusion can be done. Sometimes you have to go for anteriorly as well. For example, you can go for anterior lumbar interbody fusion as well. What are different surgical options? As I told you, it could be an anterior lumbar interbody fusion as well. For example, if you are going once you have done the fixation, but this resulted in some form of pseudoarthrosis, usually anterior lumbar interbody fusion is reserved for surgical complications such as pseudoarthrosis following the surgery for spondylolisthesis, in which anteriorly a plate has been placed pegged to the screws, and the anteriorly the vertebra is halted so that it does not actually slips forward. Then other is the more commonly done is posterior instrumented fusion, in which there are two options. One is you can go for posterior decompression and instrumented fusion, or you can simply go in for insutured instrumented fusion. If you can appreciate it over here, they've gone with some form of instrumented fusion, in which there is already a slip there, but actually they have fixed it so that it does not progress further. That is form of a posterior instrumental fusion. Other option is thoracolumbar interbody fusion can also be done, in which you can place a cage as a result, so that once not only you correct some form of hyperlordosis as well as fix the spine as well. Then the next option includes is thoracolumbar interbody fusion, discectomy along with the lumbar interbody fusion, and total disc replacement. Now that is done once the cause of the spondylolisthesis may be a complete disc prolapse and it has degenerated beyond repair. Therefore, you may have to go for some form of a disc replacement, in which so that the problem which is actually causing the slip is actually removed and the disc is replaced in form of this. But all these TLIF, DLIF, and TDR are actually rarely done. Most common mainstay of the surgery of spondylolisthesis is always either posterior decompression with instrumented fusion or posterior instrumented fusion in situ, which you can see it over here. Now coming to spinal stenosis. As I told you, spinal stenosis by definition is just narrowing of spine. There could be multiple causes which can narrow the spine. Now narrowing can be due to bony causes, or it could be the soft tissue causes. For example, if we are talking about the bony causes could be facet joint arthropathy, there could be facet joint spurs, there could be the problem could be with the degeneration of the pedicles and the facet joints as well. Now, if we're talking about the soft tissue causes, the causes of the soft tissue are usually the hypertrophy of ligamentum flavum and usually direct thecal sac compression by the ligamentum flavum, which may actually impinge on the exiting nerve root from the foramina. So when we are dealing with the spinal stenosis, one of the other causes disc prolapse or disc herniation as well. Now all these may eventually lead to spinal stenosis. So when we are dealing with the patient with spinal stenosis, we need to determine what is actually causing the spinal stenosis and what type of stenosis is being caused. I will be coming to that, what type leads to what type of stenosis. Now, if we are talking about spinal stenosis, then we categorize them into three different levels. One is central stenosis. Central stenosis is usually caused by ligamentar flavum hypertrophy. Ligamentar flavum, one gets hypertrophied, it's lying just at the level of exiting of the nerve root. Like when the nerve root exits out due to hypertrophy, it actually gets compressed between the exiting foramina as well as the ligamentar flavum, and this leads to some form of a central type of a spinal stenosis. Now, if you analyze this, usually stenosis is relatively more common in females as compared to the males, slightly more common. Plus, it mainly affects the lumbosacral spine. That is, the lumbar spine is the most commonly affected part in the spinal stenosis. And when we are, for example, if it's stenosis occurring at L4, L5 level, now there will be two things. One would be the exiting nerve root, and one would be traversing nerve root. First, you need to understand what is exiting nerve root and traversing nerve root. Then I will be discussing this categorization and why we have categorized into this. Now, at L4, L5 disc level, the exiting nerve root is actually the L4, because which is coming out, but L5 is the traversing nerve root which will exit at L5S1. So if the problem is at L4, L5, and it's a central stenosis, the central stenosis usually affects the traversing nerve root. That is, that will be affecting at the L5 nerve root. And why? Because usually the ligamentum flavum is actually creating a lot of problem. Now, the other is the lateral. There is two types of lateral. One is called as far lateral, and other is called as the lateral recess stenosis. Lateral recess stenosis is also called as subarticular stenosis, and it is actually mainly due to the problems of the facet joints. Maybe a facet joint spur, uncinate process spur, or facet joint arthropathy may lead to lateral recess stenosis. It's also called as subarticular stenosis. Now, the third type is called as the foraminal. It is also called as foraminal as well as the far lateral type. Now, lateral type is different. That is also called as lateral recess stenosis, and foraminal type is when the nerve which is exiting the foramina is actually being blocked by certain things. And then there's a far lateral type, which is actually the nerve which is trapped between the medial lateral wall of the foramina is leading to far lateral type of stenosis. Now, with the central and the lateral recess stenosis, it is always the lower nerve root or the traversing nerve root which gets affected. For example, if the problem is at the L4, L5 level, therefore the nerve which would be affected, if it's a central or lateral recess stenosis, that would be L5. But if it's a foraminal or far lateral stenosis, then the nerve which would be affected would be the exiting nerve root. That means at L4, L5, foraminal or far lateral stenosis would affect the exiting L4 nerve root. Now, what are the how do we classify spinal stenosis, and what is we need to understand that usually, if you see, this is why we need to measure the canal diameter. As the canal becomes narrow, there may be a problem eventually leading to stenosis and symptoms of spinal stenosis. Usually, the SIF is called as almost the canal area should be more than 100 mm or 100 millimeter square, but it should be at least 10 mm in AP diameter. Now, if it's at least more than 10 mm in AP diameter, this means the overall canal diameter will be more than 100 mm square or millimeter square. That is how you check it. That is one way of checking it. Is once you seeing a patient's spinal stenosis, you can go for X-rays, and then other options could be discography, which is usually not done because it actually increases the degeneration of discs. But other is CT myelography can always be done as well, or we can know where exactly using a dye which is injected into a thecal sac. We can exactly know where the problem is. For example, if you see this is a spinal column is coming, there is something over here which is actually blocking. As a result, the dye is going all the way around into this. This could be a problem, could be over here, could be a foraminal stenosis, could be a disc herniation, could be a facet joint arthropathy, could be a facet joint spur. Depending upon, there could be multiple causes which can lead to this form of problem, but they may be associated with some form of spinal stenosis. Now, what are the clinical features? First and foremost is always the backache, and this may, as I told you, may mimic with the features of cauda equina as well as spondylolisthesis as well as the vascular claudication as well. Now, there may be heaviness in the leg as well, and that is why I say they usually, the one thing is neurogenic claudication and other is vascular claudication. Usually these patients come up and complain that when I walk, after that sometimes my legs become heavy, they become numb, and it's very difficult to walk, and it actually starts to pain. Now, what makes different from the vascular claudication and the neurogenic claudication is that with vascular claudication, once that patient starts takes rest or stops walking or running, then suddenly, as the demand for the blood to the eventually peripheral muscles is decreased, there is actually a decrease in the vascular ischemia and the pain starts to decrease. But with the neurogenic claudication, if the patient is standing upright or sitting upright, the pain, instead of decreasing, will continue to have a pain despite the cessation of activity. And that is what terms the only thing which actually starts to actually help the patient is that patient asks that when I stoop forward or bend forward, that is actually decreases my pain. And that is a classical sign, because with hyperextension of the spine or bending backwards, there is decrease in the canal stenosis, and when the patient bends forward, there is increase and patient gets temporarily relieved. Therefore, this history of spinal stenosis is very important, and you need to make it sure that patient may be having a peripheral vascular disease as well. So you need to be absolutely certain that is it neurogenic claudication or is it vascular claudication which I'm differentiating with. Other causes is numbness. This may be due to the radiculopathy or may be associated with disc prolapse. Disc prolapse is one of the very common soft tissue causes which may eventually lead to spinal stenosis along as with the ligamentum flavum. Then there may be associated with chronic backache. Patient may be old age complaining of low back pain, especially increased with the backward extension. Along with once you examine the pedal pulses, the peripheral vascular may be absolutely normal. A patient may have a concomitant vascular disease, but the problem is not a vascular claudication, but problem is of the neurogenic claudication. And then that is why sometimes the symptoms may mimic vascular claudication. That patient may complain that when I start walking or running, that is when I have the maximum pain. By definition, it looks like as if due to the peripheral vascular disease, the patient is having a cramping pain in the muscles due to ischemia. But the problem is not of the ischemia, but problem is due to the hyperextension of the spine, which is actually leading to spinal stenosis. Now, once we have done the history, we have to go for the examination. We have to look for other signs of the upper motor or lower motor neurons, and sometimes usually absent. Then we may have to go for other signs such as we see whether there is other numbness of some areas or not. We can go for check for all the dermatomes as well as the reflexes. We have to look for patellar reflex, anchor reflex, as well as the tibialis posterior reflex, because they determine at which level the problem is. And then we can go for imaging. Imaging, and always the first and foremost is always the X-ray AP and lateral view of the lumbosacral spine. And when we are going for lumbosacral spine X-rays, if you see it over here, we have to look for certain causes. As I told you, the bony causes may be very much visible. There could be facet joint arthropathy, facet joint spurs, unsned process spurs. There could be spondylolisthesis as well. One vertebra slipping over another and eventually leading to some form of stenosis. And once, if we have ruled out all the bony causes of stenosis, then we may have to go for an MRI to look for the soft tissue causes of the stenosis, which includes, for example, disc herniation or disc prolapse. This may be sequestered into the spinal canal leading to stenosis, or there may be hypertrophy with the ligamentum flavum, in which the ligamentum flavum is hypertrophying and impinging of the exiting nerve root, which is actually creating the problem. And this is how we see. If you see it over here, you can appreciate there's definitely something wrong over here. There may be a disc prolapse or hypertrophy with the ligamentum flavum. You see, this is the vertebral body. This is where the space is available On one side you can appreciate the normal space, on this side is slightly narrowed space, but this may be due to the hypertrophy of the ligamentum flavum. Now once we have done the imaging, we have to define what is actually the type of stenosis. Is it central or paracentral? Is it lateral recess? Is it foraminal, or is it far lateral? If you see, this is what is actually happening. If you can appreciate over here, this is the foramina of the above vertebra. You can appreciate it's, although they are also not properly oriented and they appear to be decreasing because of disc bulge over here, but you can appreciate in this foramina it's completely obliterated, and as a result it's actually causing some form of spinal stenosis because the disc has gone out, the vertebra is flipped forward. There's also degenerative changes, as well as the disc bulge is actually leading to foraminal stenosis. Other causes, if this is another view, you can appreciate the nerves actually crossing over here. This is the exiting nerve root, this is the traversing nerve root, which is maybe the exiting or traversing nerve root may be blocked. When we are talking about the foraminal stenosis, it's always happens to be actually impinging on the exiting nerve root. That is, for example, if it's L4, L5, L4 nerve root would be affected. Now further, for example, if it's lateral recess stenosis, if you see it over here, if we can appreciate, the lateral recess is usually also called as subarticular stenosis. This may be, the problem may be with the facet joints, for example, facet joint hypertrophy, facet joint spurs, facet joint arthropathy. They all may eventually lead to this sort of a lateral recess stenosis. If you can appreciate it over here as well as over here, you can appreciate that there is some form of lateral recess stenosis compared to the other side. Now, what is the treatment? Once we have diagnosed whether it's central, it's foraminal, it's lateral recess, it's far lateral, and once we know that what nerve is actually having a problem, then what is the treatment of spinal stenosis? Spinal stenosis, initially the treatment starts with the conservative treatment. Conservative treatment includes analgesics, which include the centrally acting opioids, as well as the paracetamol, acetaminophen, and NSAIDs. All these can be initially given. The patient may be relieved of temporary pain. Patient may be advised to actually certain physical therapy and exercises in which he or she can actually maintain the spinal cord volume. Then non-impact exercises can be advised, aerobic fitness exercises in which actually the muscles are actually strengthened, so that once they bend backward, that does not actually reduces the spinal cord volume very much. Then we can also go for some form of activity modification as well. For example, the patient is having a spinal stenosis, we can ask the patient not to go upstairs or not to go uphill, because with the uphill movement, the patient will be bending backward as per the load shift would be such that would actually increase the problem for the patient. Therefore, usually we can ask them to avoid activities which involves actually moving uphill or up the stairs. Then epidural steroid injections can also be given, especially if there is associated foraminal impingement due to ligamentum hypertrophy. This can actually result in partial relief or temporary relief, at least for a few months to years as well. But sometimes it's effective, sometimes it's not effective at all. So sometimes you may require more than one dose of epidural steroid injection as well. But if despite all the conservative therapy, you have advised the patient NSAIDs, you have advised the patient activity modification, you advise the patient to go for physiotherapy and aerobic exercises, and despite even injection as well, after a few months to a year, patient is still not satisfied, or the patient is having a neurogenic claudication or symptoms which is actually deteriorating slowly over the years, then probably you will have to go for some form of a surgical treatment. Now, depending upon where exactly the problem is, that is how the surgical treatment is done. For example, if the central stenosis is there, then we can go for laminectomy with decompression of the spinal cord, with or without fusion. For example, it's at 1 or 2 level, you don't need to fuse it. But if it is occurring at more than 1 level, that will actually increase the instability. Therefore, after laminectomy, you may have to go for some form of a fusion as well. Then if it's a lateral recess stenosis, the problem is probably at the then you have to remove the subarticular facets as well as the facet joints, spurs, along with the removal of the ligamentum flavum as well. Then if it's a foraminal stenosis, you may have to actually remove the ligamentum flavum, which is hypertrophied, as well as go for actually pedicle subtraction and pedicle decompression, in which you have to improve the patency of the foramen so that nerve which is exiting and does not get impinged due to any other bony spur or due to narrowing of the foraminal. Then once that happens, then you can go for with or without decompression. So basically there are two surgeries. One is called as wide pedicle to pedicle decompression only, and then wide pedicle to pedicle decompression with instrumented fusion. Probably most commonly that involves this surgery. But for example, if stenosis has been caused by the disc herniation, then probably you need to direct your attention towards discectomy along with the fusion or not, because problem we have to address the root cause of the disease. If the disease which is occurring is actually due to ligamentum hypertrophy, then you may have to remove the ligamentum flavum. If it is due to laminectomy, you may have to go for some form of once you've done the laminectomy, you've removed increased the volume of spine, you may have to go for some form of a fixation as well. Chronic pain back syndrome may be depending upon what once the patient does presents to you with the chronic backache. What you need to understand on history is that you need to rule out all the red flags as well as the yellow flags. Plus, you need to examine the patient to rule out what is your differential. This could be simply discitis, vertebral osteomyelitis, or problem with the pyogenic infection. There could be simply the causes such as disc prolapse or disc slip, or even spondylolisthesis, or even caudal syndrome. So you have to narrow your history down and examine the patient accordingly, and then make up your differentials. So what could be the causes of low back pain? The common causes patient may present with chronic back pain syndrome includes pain and tenderness, which may be elicited especially with the lower back pain. This could be traumatic or atraumatic. A pain on pressing the spine, this is usually may be associated with slip or not. And sometimes there is actually the problem with the limb length discrepancy, and as a result there is actually having a trunk pain and lower pelvic pain, because the pain is radiated towards the back, but the problem is somewhere else in form of either arthritis of the knee or LLD. Then there could be difficulty in straight leg raise as well. SLR test actually signifies a lot of things. It could be problem of the hip joint as well as the spine, along with the sacroiliac joint as well. So when you're doing the SLR, you need to differentiate where exactly is the problem. Then there may be dysesthesia, sensory abnormalities in the dermatomes, which may be elicited as well. Or there could be, for example, associated symptoms of myelopathy, in which there may be trembling hands or dystokinesia. Then could be sweating, especially may be associated with the Horner syndrome. There may be inability to move, especially if it's muscle spasm or spasticity with upper motor neuron region, or flaccid paralysis associated with lower motor neuron region. And as the coordination due to old age as well as due to instability of the spine and sensory motor coordination actually decreases, there is actually increased tendency of this patient to fall, leading to spinal fractures. And again, chronic malunit fractures may present with a lot of backache due to malalignment. The treatment of chronic back pain is actually directed at its cause. Once you've taken the detailed history and examination, you have to treat the chronic back pain accordingly. If it is traumatic cause, for example, it's a spinal fracture, then you need to understand, is it stable or it's unstable. If it's unstable, it needs fixation. If it's stable, it can be simply treated with thoracolumbar sacral orthosis or some form of a lumbar corset. Then depending upon if it's spondylolisthesis, is it slip is severe enough or not. If it's severe, you may need to fix properly, or if it's less severe, initially activity modification and NSAIDs can be treated as well. And if the patient, you have to rule out the patient not having any spinal emergency such as caudal syndrome, because if caudal syndrome, the patient with caudal syndrome and back pain, if it left for 48 hours, this could be a disaster. So in that case, you may need to intervene early regarding for the surgery. We have covered mainly the degenerative disorders of the spine in this section. We have covered spondylolisthesis, or slippage of one vertebra over the other. This could be a number of causes. This could be isthmic or dysplastic, in which usually occurs at the adolescent, or it could be due to degenerative spine in the old age. Depending upon what is the cause, we have classified it how, according to Marding, we have 5 different grades of the slip, and what we need to understand is that how much grade 1 and 2 slips is a less severe form, with 3, 4, and 5 are a severe form of slip. Initial treatment of all type of spondylolisthesis is actually includes initially the conservative treatment. It may include analgesics, opioids, as well as NSAIDs along with the physical therapy. Once, if the symptoms settle down with activity modification, it's okay. But if there's neurogenic symptoms starts to develop, or the patient develops spinal stenosis, then probably we'll have to go for some form of a surgery, which may include posterior instrumentation with or without decompression, and then we require anterior lumbar interpodal fusion as well. Then we briefly discussed spinal stenosis, which is another form of a problem in which the actually volume of the spinal canal reduces. We have discussed what are the different bony causes as well as the soft tissue causes which may eventually lead to spinal stenosis. We have discussed the classification, which could be the central or lateral recess, also called as subarticular stenosis. Then foraminal or far lateral stenosis as well. We have discussed the concept of the stenosis affecting whether the traversing or the exiting nerve root. Foraminal and far lateral always affect the exiting nerve root, which is above 1, as well the central and lateral recess stenosis always affect the traversing nerve root, which is the below 1. And then from then we have discussed briefly what could be the cause of chronic backache syndrome. The main treatment is directed at the cause of the chronic backache. You have to take detailed history and detailed examination and first rule out what is actually causing this backache, and then your treatment should be directed at whatever the cause is of that backache. Thank you very much. Keep watching sqadia.com.